Okay, so in the second half of chapter 28, we are going to talk about the basically the cardiomyopathies and the infections that can occur in the heart. So let's start with the cardiomyopathies, and I'm sure that you have heard about cardiomyopathies because the cardiomyopathies, especially this arrhythmogenic right ventricular cardiomyopathy, that's the one where people don't really know that they have it, and it typically shows up in athletes, and they're the ones that are like out, the basketball players out on the court, running up and down the court, and all of a sudden he falls down and dies, just sudden cardiac death. So that's the cause of a cardiomyopathy. So what happens in a cardiomyopathy, and there's a bunch of, not a bunch, there's 3 or 4, kind of 5, but there's sort of 4 ones that you need to know about of the cardiomyopathies. And basically what happens, the commonality of all the kinds of cardiomyopathies is that the actual muscle of the heart is ineffective. It's not the size that it's supposed to be, and it's not doing what it's supposed to be because it's getting, it's structurally is kind of getting out of whack. The most common of the cardiomyopathies is a dilated cardiomyopathy. And what happens in a dilated cardiomyopathy, and tons of things can cause this. We're finding out now, like postpartum, some women are developing cardiomyopathies. But a dilated cardiomyopathy is where this ventricle, and this is going to be a normal sized heart, but in a dilated one, the the ventricle is way out here. You still have the same amount of blood and everything coming out. The inside of this ventricle is still the same size, but it's the walls are just too big. So the problem is when you're thinking about your cardiac output, you have the same amount of blood coming in here, but now all of a sudden the chamber to hold it is way huger. So then when that chamber contracts during systole, it takes much more force, and it has a much harder time getting the blood out. So this is called a dilated cardiomyopathy. The arrhythmogenic right ventricular cardiomyopathy, what happens here is that the cardiac muscle here in the ventricular walls starts getting fibrous. So instead of the heart like being able to beat with every normal beat, it starts getting fibrous. It's like a scar tissue. And you'll know, like, think of a scar that you have in your own body that's very fibrous. It's different than regular skin tissue. It's scar tissue, and it's meant to do that. It's meant to hold it really tight so that that area that got injured doesn't get injured again. That's the whole point of fibrous scar tissue. But for some reason, people that have this condition, arrhythmogenic right ventricular cardiomyopathy, these fibrous bands start laying down in the ventricles. And again, this becomes a cardiac output problem. So now if that ventricle is trying to get that blood out and it can't because it's too fibrotic, you're going to have a cardiac output problem. So you're going to see respiratory problems, you're going to see edema, you can start seeing JVD, but sometimes you don't know this is occurring until somebody just has sudden cardiac death. Hypertrophic myopathy, this is rare. It's a little bit similar like to a restrictive one. But the hypertrophic, you just, again, get big, huge, really thick muscle in here like this. Way too big. It's just entirely too humongous. And a big septum in the middle, way too huge. So you can see when that starts getting way too big, again, now you just restricted the area for you to get your cardiac, your cardiac output in. The hypertrophic is rare. They think it's autosomal, like the body is all of a sudden not recognizing the heart muscle and kind of starts attacking the own heart muscle. And that one has, it's like an asymmetry. The heart muscle starts becoming asymmetrical. The restrictive ones, Also start getting non-malleable walls, start laying down fibrous tissue in here. Basically, with any of the cardiomyopathies, it is a problem with the muscles, the cardiac muscle itself. It's either getting too big, too dilated, or too restrictive, non-malleable, and it can lead to some very significant problems. So the patients who have a known cardiomyopathy, and this is why now they're starting to, in high school athletic programs, they're starting to do echocardiograms and stuff so they can see if a patient or if an athlete has this before they allow them to start playing sports, because oftentimes there's no symptoms until they are requiring that heart to do more, and then that leads to problems. Sometimes, like especially in the dilated one, some patients are just higher risk because there's a lot of causes. If they can't identify the cause, if they don't know what's contributing to the heart having a cardiomyopathy, it's called idiopathic. Idiopathic is the word that we use in the medical world for we don't know what it's coming from. We also call that unknown etiology. So we don't know where it's coming from. It's an idiopathic cardiomyopathy. These patients need to be on a low sodium diet. They are at high risk for heart failure and fluid overload. So you put them on a low sodium diet because sodium contributes to fluid overload. Water and salt follow each other. So you put them on a restricted salt diet. And let me get out of this one thing. Okay, so in a patient, when you're doing your assessment, if a patient has a cardiomyopathy, they will probably, hopefully, have chest pain before they have a sudden cardiac event. So a lot of them will start complaining of chest pain. Their EKG won't change if they have not had an MI, and so they're still having chest pain with an unchanged EKG. It could be an indication that they might need an echocardiogram to determine whether or not they have a cardiomyopathy. This does tend to run in families, so you want to get a good family history to find out if a close relative has had this. Another thing that you want to check for in your patient who you're suspecting has a cardiomyopathy, the heart sits in the chest like, kind of like this. And right at the fifth intercostal space is where the apex of the heart, every time it beats, it kind of comes up like this. That's called the point of maximal input, the PMI. And you can, like when you're assessing a person, you can feel it. In people that have cardiomyopathy, that might be very huge and not just limited to that one intercostal space. So you do want to assess for that. They might have additional heart sounds. These patients often, you can hear S3, S4. You can hear murmurs going on. Sometimes they'll have JVD. If they've got right-sided heart failure, they start having JVD and edema. If it's especially coming from the left side, you're going to hear rales and crackles in the lungs. They are at high risk for decreased cardiac output. So you need to watch for all of the other organs that are not getting the oxygen components that they want. They're at impaired gas exchange, activity intolerance. There's about 1 million nursing diagnoses you can give these patients. The other problem with this is, especially if a patient knows that they have it, it is very anxiety producing, because the people that have cardiomyopathies know there's something wrong with their heart. They know that they can have a sudden cardiac death event. So some of the patients also wear AICD device, an automatic implantable defibrillator device. Patients that walk around with those, they end up, kind of getting psychotic, because they walk around in this fear of please don't go off, please don't go off, please don't go off, because it's like when you get shocked, that shock is coming, and it's scary and uncomfortable, because those implantable defibrillators, they can feel the shock going to the heart. It hurts. So that's problematic. That's a a teaching and a social issue you have to deal with in your patients who have an AICD. They can have all kinds of dysrhythmias because these muscles, if you'll remember, your sinoatrial node comes down here and then to the AV node and then the Purkinje fibers up through here. This charges the electrical stimulation to the heart. Well, if you get down here and all of a sudden these muscles that are trying to get stimulated are not working, or they're fibrotic, or one leg that has rhythmic problems in it, these patients can have all kinds of electrical problems. So they can be developing VTAC, VFib. They can throw a lot of extra beats, PVCs, PACs. So the patients often have to be monitored very closely with EKGs. And you really want to do anything you can to increase the patient's cardiac output. Oftentimes, depending on how bad it is, they might have to be on supplemental oxygen because, as we've talked about, it's a cardiac output problem, so they're not getting as much oxygen to the other parts of the body. They have to allow for periods of rest, and don't ever underestimate allowing for periods of rest. So instead of getting up, fixing breakfast, doing the laundry, vacuuming the house, going to pick up the kids from school, you just do one thing. Get up, teach your patient to get up, have breakfast, then sit back down. That way the body can rest, can recuperate, can get the oxygen back to the muscles and the lungs and everything that is just expended, and then get up and do another activity. So resting between activities is often a good idea, especially in patients who have this kind of a situation going on. This is really problematic if your patient is an adolescent and an athlete and they want to keep being on the team. So that's really traumatic for a young person who wants to be involved in sports. So that is going to involve some social support and maybe some psychological support for these patients. Maintaining good vital signs, and sometimes they have to be on some medications. They might need to be on medications like some of the beta blockers to slow down the workload of the heart. Some of them, like if it's, depending on which one, might need to be on digitalis, which increases the contractility of the heart. You do need to be careful on your patients who are receiving digitalis, and I'm sure you've studied this in pharm, because patients can develop digitalis toxicity, and they'll come in and they'll be nauseated, vomiting, they don't want to eat. You need to check the dig levels because people can get toxic to dig, although it's a good drug. Those are some other things you have to watch for in your patients who have cardiomyopathies. Probably, again, they're going to be on the blood thinners or the aspirins and stuff like we talked about with some of the other, like the valve problems. So these are the cardiomyopathies. If the patient is getting too symptomatic and the symptoms can't be controlled with medication, and the risk of like a lethal arrhythmia or cardiac death is high, the treatment of choice for these patients is heart transplant. So if a patient, especially in young people who have a high-risk cardiomyopathy, they're the ones that go on the cardiac transplant list. So that's obviously weighs heavy on a patient's heart when you tell them, I mean, or on that, no pun intended, I meant it weighs heavy on their mind. Then they have to go on a cardiac transplant list to get a new heart because there's really no way to fix that. You can't, there is a procedure where they can go in and they can scrape some of this out inside the ventricle like that surgically and open that up for the hypertrophic and the restrictive ones, but that's not always successful, and it's a sort of a bigger surgery, so if possible, they put them on a transplant list. But obviously, it's not the easiest thing in the world to get a transplant. So some people end up, dying or having a very significant dysrhythmia while they're waiting for the heart. So that's the problem with some of these cardiomyopathies. Okay, then the other thing I wanted to talk about this further in this chapter are the infections that can occur in the heart. And you basically, in the heart, you have 3 layers to the cardiac muscle. Let me put my heart back up here. You have the inside layer, and this is around all inside the heart. This is called the endocardium, the very inside lining of the heart, like this. It's around all of the chambers. This is the endocardium, and this can get infected and cause vegetation in here. That's called endocarditis. Endocarditis. And the signs and symptoms of that are chest pain, and typically somebody might describe that they've had dental work done, recent surgeries, a recent illness, something that has entered the bloodstream and has now landed in the heart. It's causing endocarditis. The middle layer of the heart here is called your myocardium. This is the big part, the big layer of the heart. This is the one that's responsible for the contractions of the heart. So you kind of need this guy working because this is the part that contracts. Your patient can get an infection there, and it's called myocarditis. Again, patients who have been immunocompromised, they've had recent dental work or surgeries, they can develop myocarditis. Patients who have, I forgot to tell you, this is why it's so important when your patient starts getting a sore throat that you want to get that throat swabbed, because if it turns out that that is streptococcus, untreated streptococcus is a big contributor to endocarditis, which is why in the past, patients who we didn't know about strep throat, streptococcal virus, and it went untreated. So that's why a lot of people then would get rheumatic heart disease because they had untreated streptococcus, which ended up in causing an infection in the heart, and then that leads to rheumatic heart disease. It's not as common now as it was in the past, just because there's such easy methods to determine if somebody has strep throat. That's why your patients if that strep test comes back positive, you need to get them on antibiotics right away, because, well, you can eradicate the infection, but you really want to prevent that infection from getting into the heart, because then that can lead to cardiac disease. And then the last thing is pericarditis. Pericarditis is on the outside lining of the heart, out here. This one is more common after your patients have had an MI, which really makes sense because, if you think of an MI, it's these coronary arteries that are coming around and feeding the outside of the heart like that. And then that causes ischemia. And so sometimes your patients who have had a heart attack, an MI, can develop pericarditis. And pericarditis is just an infection on the outside lining of the heart. So the pericarditis tends to be more painful because that heart muscle starts swelling up, and it gets like an infection on the outside of it. It causes a lot of chest pain. You can hear a pericardial rub, and people who have pericarditis, if you're listening to their heart, you can hear this rub, and it kind of sounds like that. What's happening is every time that heart is beating, it is rubbing up. It's inflamed because it's has an infection in it, and it's rubbing up against the pericardium, which is like the sac, the pericardial sac that encompasses the heart. and it's just getting too enlarged and it hurts. So a really good treatment of choice for your patients who have pericarditis, they do need to be on an antibiotic. But the NSAIDs work great for pericarditis, Motrin, ibuprofen, things like that, because it will reduce the inflammation, which is causing the pain. Another thing you can do in your patients who have pericarditis is lean them forward like this, because when you lean forward, you're pulling that heart away from the lungs, and it just gives it more room. Your patient will feel better. So you can just sit them up at the bedside, have them lean on their bedside table, and that really helps some of the pain of pericarditis. In all of these scenarios, the patient has to be on an antibiotic, a good antibiotic. With endocarditis, you need to be careful if it is vegetative, like if the infection is starting to grow in here around these valves, because this vegetation can break off, and then if it breaks off, it acts just like a clot. It can swim upstream or something like that, and I don't even know who that is, and can cause the same kinds of things like PE or stroke, or if it goes to the kidneys or wherever it's going to go, it can cause an emboli. Okay, so that is, and one way they can figure it out is they can do an echocardiogram. They can go in and look at the heart, doing like in cardiac cath or something like that. So there's a couple different ways to diagnose that. And most of your patients who have one of the itises, endocarditis, myocarditis, pericarditis, will have the same kinds of symptoms that anybody else who has an infection. They won't feel good. They'll have general malaise. They will probably be able to, it'll be sort of confined, not confined, but sort of targeting in the chest area, but it's not like the acuteness of like an MI. They will have a fever, their white blood cells will go up, they could, depending on how bad it is and when you got it diagnosed, they can have dyspnea, they can have fatigue, and then the key here, one is to prevent it, and two is to treat it earlier than later. Patients who have this can have a TEE, that's a transesophageal echocardiogram. This is an echocardiogram where they go through the esophagus, but they can get much closer to the heart through the esophagus, and they can do an echocardiogram that way. That's called a TEE. A lot of your patients will have that done. Once a patient has had an endocarditis or myocarditis, typically they have to go on prophylactic antibiotics before dental procedures. Especially with endo and myo, not always with pericarditis. These patients should always be getting their flu shots, their pneumonia shots, because you want to prevent this from reoccurring in somebody who's had that already. Okay, so I think that's it. So that's the cardiomyopathies and then the infections of the heart. Another thing you can do with pericarditis is if the pain of that gets too bad and the inflammation is too bad, they can do what's called a pericardiocentesis, where they go into the sac that's around the heart like this. And this, because of inflammation and the infection, this around the heart can start swelling up with fluid. This is what your body does when there's an infection, is it gets swollen and inflamed and filled with fluid. However, what can happen, because it's sitting right there in the chest wall surrounded by those ribs, so there's not a whole lot of space for it to go. And so if this gets too inflamed and too fluid filled, they can do a pericardial centesis, where they go in through the intercostal space with a large syringe, and then they just withdraw fluid. They pull fluid out, so this fluid then comes in here, fills up a chamber. That's called a pericardial centesis. It's removing fluid between the pericardial sac and the pericardium in order to relieve some of the pain of pericarditis. Because if this gets too significant, if the fluid around the heart gets too much and there's nowhere for it to go because of the rib cage, it will start kind of coming back in on itself, and that's called cardiac tamponade. A tamponade is, it's kind of like putting that heart into a vice. Basically, all of this inflammation and swelling, it can't go further because you got your rib cage right there. So it starts compressing down on that heart. That's called cardiac tamponade. Obviously, very high risk for some very significant complications because you've just reduced the ability to maintain cardiac output. So that heart that is trying to, you know, in a normal beat would go like this. Well, all of a sudden, if you've got a cardiac tamponade going on, that heart, it can't expand like this because it's against fluid. So it's trying to squeeze, but it's unable to take that, you know, that to completely fill during diastole. It can't fill enough because it's being restricted. That's when it gets to that point. If you had better go in and do a pericardial centesis, or you could lose your patient. So those are that's it in a nutshell. Read the rest of the chapter that explains. It goes into a little bit more detail about some of the specifics about the different myopathies and what to do, like how they're treated and stuff like that. So that's it.